And sorry for the delay, but this is our first meeting of the Budget Review Subcommittee for Health and Family Services. And as a reminder, please, there's no remote attendance by members as are permitted on the 2025 interception. All members must attend in person as recorded as present. The meeting materials have been online and made available for downloading. And at this time, I'll ask the secretary to call the roll.
Senator Berg. Present. Senator Tichenor. Representative Duval.
Present.
Representative Fleming.
Present.
Representative Johnson. Representative Raymer.
Here.
Representative Wilner. Representative Wilson.
Here.
Senator Mays Bledsoe. Senator McDaniel. Senator Meredith. Representative Bowling, Representative Bray, Representative Heverin, Representative Moser,
Here.
Representative Petrie, Senator Richardson, Representative Williams.
Here.
Okay, I believe we have quorum, and we can go ahead and proceed. I just want to take a first of all personal note. Representative Williams will be taking over his chair in the near future. I assume that's already out. If not, it is now. And I'm going to be taking on a new role, which is not out yet, but some of y'all might already know. Is taking on a new role as chair. So the next time, I think Representative Williams will be the chair. Today was supposed to be Representative Richardson's time. Sorry. Senator, thank you for the correction. Senator Richardson is supposed to be the chair. He was not able to make it, and so we're basically filling his void in order to continue to keep things going. Today we have. So anyway, we're the focus today is going to be on Medicaid, and I know the commissioner. Lee and the Chief Financial Officer are here, so if y'all don't mind, come on up and identify yourselves for the record. And I ask the members, if you do have a question, just let me know. But let's go ahead and let the presenters go through their presentation, and then we can answer and entertain questions afterwards. So if you don't mind, just raise your right hand, repeat after me. Yeah, you swear to tell the truth, whole truth, nothing but the truth?
I do.
Very good. Thank you very much. Proceed and identify yourself. Thanks.
Hello, I'm Lisa Lee. I'm the Commissioner for the Department for Medicaid Services.
Steve Bechtold, the Chief Financial Officer for the Department of Medicaid.
So we usually put this slide on here, just Medicaid at a glance, 1.4 million members, over half of the children enrolled in the state, 485,000 expansion members, and we have over 69,000 providers that deliver services to our members. So today we are here to talk about our compliance with House Bill 695. So House Bill 695 requires Medicaid to obtain authority from the General Assembly before making changes to eligibility, services, or benefits in a state plan amendment or for a new, amended, or renewed waiver. So, and it also sets up the timing and the type of the physical impact and necessary information to be provided to the Legislative Research Commission. The bill does exclude Medicaid preferred drug list and previously approved directed or supplemental payment programs. We do have some supplemental payment programs in which we pay certain providers, such as hospitals or ambulance providers, enhanced payments, or if you will, or directed payments. And those have to be approved every year by the Centers for Medicare and Medicaid Services. So those are exempt from the requirement that we submit those to the General Assembly for authorization. It also includes federal requirements, national emergency and disaster declarations, as well as any governor's declaration of emergency, along with we also have to submit a fiscal impact to the Legislative Research Commission. So submission of waivers. Currently, the department has several waivers. We have 6 home and community-based waivers, which are 1915C waivers. We have 2 1915B waivers. Those waivers include the managed care organizations and the non-emergency medical transportation benefit. We also have one 1115 waiver, which is currently the reentry waiver that you may have heard it referred to as the incarceration. Typically, Medicaid cannot cover individuals who are incarcerated. This waiver, the 1115 waiver, allows us to provide certain services in the carceral setting prior to those individuals being released in order to have them be more successful when they reenter society. All of those waivers have to be renewed at different times. For example, the 1115 waiver is for a 5-year period. It has been approved, so in approximately 5 years, we will need to submit that for reapproval. But the waivers can be amended at any time. So if we have to amend that waiver, we would have to submit that information to LRC before we submitted that waiver to CMS for approval. Reasons that we would amend a waiver include an increase in slots allocated for those 1915C waivers, or any policy changes that would impact services, reimbursement, those sorts of things. And so we will provide a copy and be in compliance with this portion of House Bill 695 as we go forward, and will provide any additional information upon request. Our community engagement waiver is also part of House Bill 695. It is currently in the public comment period and anticipated to meet the deadline for submission to CMS, the Centers for Medicare and Medicaid Services, which is July 1st. We had a 90-day time frame to turn that around, and we believe that we are going to meet that deadline for submission. There was also a provision for us to create a Medicaid pharmacy rebate fund, which has been completed. There was some requirements for reporting and expenditure data collection from managed care organizations that was submitted to LRC on May 14th of 2025. New reports that we will have to be submitting to LRC as we go forward is a budget analysis on a quarterly basis. We did submit our first one May 7th of 2025. We also have an expenditure report that for MCOs that was submitted May 14th of 2025. We have an enrollee quarterly report. We are expected to submit that in late June of 2025. We also have the provider tax assessment report, which is in progress, and a behavioral health trend report that is in progress that requires us to submit any trends that deviate 10% through the year. So we are putting in provisions to make sure that we can pull that report and have it on time. There's a legislative Medicaid impact notice. So if we believe there's a barrier to implementing anything in this bill, that we will have to provide LRC in writing the barriers within 7 days. So we have developed a process to be in compliance with that provision of the bill. There was some non-codified language in House Bill 695 requesting that Medicaid reinstate all behavioral health prior authorizations for services in place and required on January 1st of 2020. We have completed that process. And by December 31st of this year, we will have to develop a scorecard for behavioral health and substance use disorder treatment services and for providers to be used by all managed care organizations. And that is in progress. We are working with our partners in the Department for Behavioral Health, Developmental and Intellectual Disabilities to assist us with creating that scorecard. And now I will turn this over to our Chief Financial Officer to talk about the budget.
Thank you. In 2025, what I show here is our total budget, which means we have two appropriation units, one administrative and one benefits. Medicaid benefits. So that's both codified in the budget bill. So what we did here was provide you the budget, the total budget by fund source, federal funds, general funds, and restricted agency funds. I showed you the expenses as of May 23rd of 2025, which gave us a remaining budget of about $2.2 billion to go through the month of June. Our remaining expenditures that we've projected is about $1.9 billion, a little over 1.9, almost $2 billion that we have remaining, and a lot of that is due to ATRIP. We had one more ATRIP to pay at the time, which is a huge. Let me back up. Hospital rate improvement plan is what ATRIP is a directed payment. So we had a huge payment there, as well as one more MCO, managed care organization capitation payment. and that was the largest two expenditures that equate that kind of added into this almost $2 billion. But as you can see, we're if our projections hold true, we will spend $20.6 billion. That's taking the current expenses, adding in the remaining expenses is how you come up to that. And we'll be right around our total budget of 98.73% of our budget is what will end up the year. So the next slide, we just broke out the benefits budget for you. So that previous slide was, if I just remind you, that was admin and benefits. This is just the benefits. You can see it's the same type of layout. It's the federal funds, general funds, and restricted funds. And you can see that the largest piece of that almost $2 billion on that previous slide is in benefit payments that we still have outstanding. But we project that by the end of this year, after you look at those projected expenditures, that we will be about $20.3 billion will be what we spend on benefits alone, and we'll be within 1% of the budget, which is 99.24% will be what we spent. You can see a majority of that, a large piece of that is going to be federal funds, and that's due to what we anticipated, what we budgeted. We budgeted at a higher FMAP than what we actually received when we did the budget exercise, so that's what equated to that. The last slide that I'll present on, I think you asked for administrative budget, so we also broke out the administrative by personnel, and you asked for it by, I think we call it object type. I believe you all called it class, but the object type is personnel cost, operating expenses, grants, loans, and benefits. And you can see our budget, what we've expended through May of 23, what's remaining in our budget, and our projections of how we're going to end. I will say this. It says we're going to be within 73.57%. We're going to spend all of our state funds. All of this is going to be federal funds that's going to be left over. So when I say state funds, I mean our general fund and restricted funds. We're projecting to spend 100% of that. The reason for the excess federal funds is due to IT services where we get 90-10, that we might have not gotten 90-10. We went to like 75-25 FMAP, the federal matching percentages. And so that's what drove that. But we do anticipate spending all state funds that have been allocated to us.
And our last slide just demonstrates the number of individuals, staff in Medicaid. We currently have 211 filled positions and 11 vacant positions within the department in air personnel. And with that, we will answer any questions you may have.
Okay, thank you, Commissioner. Thank you, CFO, on their presentation. And I know some members have some questions, but let me start on just a couple, I guess, technical things. The 11 vacancy, are they spread across, or what's the makeup of the 11 vacancies? In terms of functions and what they perform.
I would have to go back and get that information, but they are spread across the entire department. The department has the commissioner's office in 7 divisions, and they are spread across the department. I would have to go back and look at those specific functions.
Okay. Going back to your, well, I got several questions. Let me take the one on. It's about the non-codified 695 language. I think you mentioned there about a scorecard.
Yes.
Could you give me a little more detailed information about the scorecard? Who's performing that particular scorecard? What do they do in terms of going through that process? I assume they're going to go to all the providers and use some type of metrics, and have you ever approved those? Could you just give me more detail about that?
We're still in the process of developing that. As I mentioned previously, we are working hand in hand with the Department for Behavioral Health, Developmental, and Intellectual Disabilities They have developed certain information, quality metrics that they have been looking at that's still in draft form that they will be using to develop that scorecard as we go forward for the MCOs to use. And I can get additional information on that for you from the Department for Behavioral Health. They are taking the lead on that project.
Okay, so you don't know if somebody's been hired already or anything about that?
No, we don't anticipate hiring anyone. We will just use the Department for Behavioral Health to develop that scorecard for the MCOs to utilize as they go forward.
Okay, okay. All right. Well, if you could follow up on this about that, I'm getting conflicting information, so I'm just trying to get some clarification that they've hired somebody. This is a provider that might be doing the scorecard, which may be a sort of I don't want to say a conflict, but sort of cause a question in terms of a provider going in and scoring the provider. So if you could clarify for that for me, I would really appreciate it.
I do know what you're talking about. There is a provider that does certain quality metrics.
Okay.
I'm not sure how involved they're going to be in this process. They do work with certain managed care organizations, but I don't think they work with every managed care organization. But I will follow up with you now that I know the context with their exact role in this scorecard process.
Okay. And one last question I'll turn over to members of the committee on their questions. The community engagement waiver, I know that's going back in the Bevan administration and went to courts and so forth. Could you give us a little brief history of where that has come from and where we are now today?
Definitely. So in the previous administration, there was an 1115 that was submitted to CMS regarding work requirements that had a lot of different components in it. The department has been working with workforce development because we definitely do believe in assisting individuals and connecting them with employment. We have been working with workforce development and sending them information related to individuals who requested workforce information and assistance in locating a job. With our new waiver, we are making that mandatory. Previously to House Bill 695, it was optional for individuals to have their name sent to Workforce Development to request information. Now it's mandatory. We have a listing of individuals who it will be required mandatory that they are connected with Workforce Development. Workforce Development will help them find employment within their counties.
And how do you see what the feds are doing in terms of the workforce and workforce requirements in regards to what we're trying to do? Do you see any, I guess, could you see how that's going to interface, how that's going to work between the two?
We're not sure just yet. We do know that the Centers for Medicare and Medicaid Services will come out with additional guidance by December of this year. That is their target, to come out with guidance related to community engagement. And so we are still moving forward as outlined in House Bill 695 with submitting our community engagement waiver, and then we will engage with CMS as soon as it has been submitted to them.
Okay. All right. Thank you, Commissioners. Senator Berg, I believe, has a question.
Thank you, Mr. Chairman. If it's okay, I think I have two questions.
Go ahead.
On the first question, what percentage of these $2.3 billion that we're talking about, essentially, right, is federal money versus state money? Is it 90-10? No.
Are you talking about the which slide are you asking?
The actual benefits, not the administrative costs.
So on the benefits, it's about 80%.
80% federal dollars, 20% state dollars.
Correct.
And do we have any idea what the anticipated decrease in federal dollars is going to equate to?
From the reconciliation bill that's
Yes.
we do not have any I don't think that is finalized yet, so we have no idea what could be changing on the Senate side before it becomes law.
So we have no way at this point to start anticipating the needs of the states.
Well, we understand that as written and as passed right now, that there's a freeze on provider taxes. There is a cap, so to speak, on our ACR, our average commercial rate limitation on our directed payments. But that's pretty much what we know to this point. There's also a community engagement piece that they've put into that bill that we're going to have to see how that changes our waiver that we just submitted. So there's nuances. There's several different things that are still unknown at this time to give you that kind of.
Do we have a worst case scenario yet? I mean, that's where we should be working from.
We have developed some modeling because there are various scenarios that could come into play. For example, reduced FMAP. There are some provisions related to, as Mr. Bechtel referenced, community engagements. There are also references to cost sharing for certain Medicaid populations. Based on what the House bill passed, we have kind of looked at those provisions. But as far as what that final bill is going to look like, we have based our modeling on the House bill as it passed. So we still have to maintain our interest in the federal space, and we are working with, for example, the National Association of Medicaid Directors with certain provisions that are coming out and making sure that we are aware of what is being discussed so we can sort of model, but until that bill is finalized at the Senate, we're not really going to be able to know how much we're going to have to pivot and how much it's going to impact our program within the state. But any impact at all is going to be detrimental to the Medicaid program. If we lose individuals from the rolls, definitely that's going to impact our hospitals. We're definitely concerned about the hospitals, especially our rural hospitals. But any reduction in benefits, any reduction in provider reimbursement is definitely going to be detrimental to the state.
And I will just add that with regards to the cost sharing, as well as the community engagement that they have in their bill, that will require some IT, some administrative cost that it's going to cost us to make our systems be able to do what it needs to do. So there will be an expense on the admin side. So I just wanted you to be aware of that.
Yeah, and Senator Berg, I believe when Steve mentioned about 80%, that's a mixture between expansion and traditional.
And
'Cause
CHIP.
expansion is around 90%, and traditional is around 71%. You do have administrative, which pulls down around 50 or so percent. So it's a mixed bag of things. So it's probably what have added what you're referring to.
Correct.
And then the other thing I think you mentioned, in terms of the federal bill, the reconciliation bill, I don't believe there is a change in the FMAP at this point.
No.
But I know y'all came here back to spring. Yeah, y'all testified that for every 1 point, it's around $75 million, which probably is actually probably around $100 million. For every point that goes down, you're looking around $75 to $100 million impact to our budget. So that is a significant issue that we need to be mindful of and concerned about. So
And what you're mentioning there, Representative Fleming, is the expansion 90-10. So
That's right.
So if 90-10, at that 90-10, they at first was discussing making that the same as our traditional FMAP, which would have been like our 71% that we're at. And if that was to happen, it would be detrimental to the budget.
Yep, and that's why in this bill, we had the Medicaid Oversight Advisory Board. It comes up to try to peel all that stuff back, which I know this board will be working with y'all closely in terms of trying to prepare ourselves, whatever the feds might do.
And
Who
everything
knows what
that
they're gonna do.
Representative Fleming said is correct. I will just add that there's also the CHIP population that gets 80-20. So that's in that mix too.
Yeah.
Does anybody else have questions or comments? You could, and you go ahead, right ahead.
Do you all have any idea what percentage of our current eligible population on Medicaid, one, is working, or two, is work ready?
We can get those numbers. Our eligibility information, and I think that's Representative Fleming, some of the information that you all have requested in the reports and in House Bill 695 does request the number of individuals who are working full-time or part-time. We do capture hours, so that information will be coming over in that report as soon as we get that. And those that are work ready, when we talk about the community engagement and connecting individuals with employment, there are certain individuals within the Medicaid program that would be exempt. That's based on the bill itself and based on, are they able to work right now? Do they have a chronic condition? Substance use disorders, individuals with substance use disorders are exempt because they are in treatment. So as far as work ready, we can go back and look at those kinds of conditions and those that we have exempted to tell how many individuals would actually be impacted by the community engagement waiver. And I believe that number is spelled out in the waiver application itself. So that number in that waiver application, and I'm sorry, I don't know what that is right now, but that would be the number that we believe would be work ready.
And I'll say that, we have a total population that we serve of 1.5, around there, right, give or take. So 1.5 million. And those who are exempted are your age blind, disabled children, So that's your CHIP population and your traditional Medicaid population. So basically you're just looking at the expansion population on the work requirement, which we're around 450,000 people. So you're down to 450. So if you can do it keeps lower and lower and lower. Right. It's a very small amount, but I don't know how small to tell you.
Yeah. Senator Byrd, you use your mic, please. It's okay.
So you don't think actually it's going to have a significant impact on the number of people affected? You're saying it's going to be a small group?
Yes, we believe it is going to be a small group.
Okay, thank you.
When y'all mentioned about eligibility, and I have looked at some, and I'll get probably teased about this. I looked at flow charts, and flow charts really helps me out to visualize things. It seems that y'all go through a process, and in terms of looking at who's eligible, and if they're not eligible for one, you put them on reserve. They might be eligible for another, and it just I don't know if there's any duplication that's going on during that process that would need to be mindful of. Could you explain for the committee just a little bit about your process in terms of eligibility and making sure that these individuals are put into this program and not, not duplicating your efforts and time?
Yeah, absolutely. So the Medicaid eligibility process is the most complex process that you can imagine. We typically say that we have 6 categories of eligibility: age, blind, pregnant women, aged to 65 and over, blind, pregnant women, children, and age, blind, disabled. And then you have the Medicaid expansion population. So you would typically think that somebody would fall in one of those buckets, but underneath all of that are additional criteria. For example, everyone has to meet a certain level of poverty level. Their income has to meet a certain level. For example, for the expansion population, we know it's at 138% or below. But you can have some families who have, for example, a child under the age of 1 whose eligibility is based on a higher poverty level than a child who is aged 6, for example. So our system, we do have a very sophisticated integrated eligibility and enrollment system that actually looks at every bit of the information that comes in, and it can bucket those individuals into the correct category of service. We usually call it a TOA, which is a type of assistance. We have several. Couldn't even tell you how many types of assistance that we have in our system, but our information technology system that does that is so sophisticated that it typically would not end up in someone being in 2 different categories unless, for example, there was some issue with a name not matching. But in that case, we can always find those, and if there is an instance where somebody has duplicate eligibility, it is corrected very quickly. If there's some like for example, a good example are newborn babies that are eligible for Medicaid. They don't have a Social Security number, so we connect them with their mother, and as soon as they get that Social Security number, we make sure that they are moved into a different category of service based on that information. So very sophisticated. We have one of the better eligibility and enrollment systems in the nation, and as a matter of fact, several states have used our platform and built theirs to ensure that their system is as accurate and as current as ours.
Do you see any influence from the feds in terms of looking at the eligibility process and criteria?
There is a provision in the reconciliation bill that requires that we look at eligibility for the Medicaid expansion population every 6 months. Currently, we do eligibility renewals or recertifications annually. However, our system, as I said, is pretty sophisticated. And so when individuals complete an application, we have access to various data sources such as the state wage index, the federal hub. We also have access to birth and death certificates and vital statistics. We have access to driver's license and transportation. So we can actually verify individuals' information throughout the year. And we do some of those checks on a routine basis to make sure individuals are maintaining their eligibility. And in addition, individuals have to submit to us a change in circumstance, such as a change in their income or a change in their household size within 30 days of that occurrence happening, which also allows us to make sure that individuals in the program are eligible for the program.
Do you take a random check, or is it more of a broad approach? You
It's a
use
broad
the word
approach.
some.
Yeah, it's a broad approach to go in and make sure that that our eligibility information and individuals who are enrolled are eligible.
Okay. All righty. Any questions from the committee? Okay. I should slap my hands, make sure everybody's awake. All righty. Is there anything else I'd like to add, or anything else that we need to know? I know there's a lot of things there's going to be fluid coming from the feds, and we need to embrace ourselves in order to address this. So it's going to be a pretty big lift for the state to go through and try to deal all that. So anyway, anything else you'll have to add?
Well, yeah, I just, can't stress enough the importance of the Medicaid program and the population that we serve, the aged, blind, disabled, pregnant women, children. I mean, over half of the children in this state are either on Medicaid or K-CHIP. There's just any change to that program, regardless of what it looks like, is going to have an impact somewhere else. But the bottom line is it's always going to impact our providers, because any change in the Medicaid program results in a decrease in reimbursement to our providers if we decrease eligibility, for example, or if we reduce benefits. It always ends up in our providers who have been serving this population and are committed to this population. So we're definitely keeping our eyes on everything at the federal level, but this is not going to be something. If we have to start making changes, I think the Medicaid Oversight and Advisory Board is going to be very critical. Some of these changes may have to be made very quickly, and so we appreciate the opportunity to come over and talk about Medicaid, give information. And Representative Williams, congratulations on your new role going forward. We'll look forward to working with you. But we're just here to provide any information to help individuals make the best decisions possible to ensure that our members continue to receive the vital services that they need.
Right. I mean, it's going to be it's going to be a pretty big heavy lift. But we didn't look at the MCO contracts. We need reimbursements. You got the provider tax. You've got quite a few different things we need to peel back. And a lot of those things can tip the apple cart. Mm-hmm. And so we need to go through a very prudent and a systematic approach in order to address that. So anyway, anybody else have anything else? Okay. All right. Well, thank y'all. Let's see here. Oh, okay. So before we adjourn, just make sure the members know and the folks in the audience know that our next scheduled meeting is July 15th. And if there's not any other comments or questions from anybody, I have a motion to adjourn. So move. Okay, we stand adjourned. Thank you all very much.